Hi everyone and welcome. This is another research of mine about electronic medical records risk management in Kudus hospitals, a comparative qualitative study. Before going in, let's meet the team.
First, let me introduce myself as the first author. Cikita Berlian Hakim holds the position of engineering lecturer at Universitas Muhammadiyah Kudus.
As the second author, I am Jeki Pornomo, holds the position of Health Administration Lecturer at Universitas Negeri Makassar.
Third author, Ingrid Novi Ariani, is a hospital administration student at Universitas Muhammadiyah Kudus. Last but not least, the fourth author, Taufiki Dwi Wijayanti, is also a hospital administration student at Universitas Muhammadiyah Kudus.
As you can see in the table, the author 1 and 2 shared the leading part, and author 3 and 4, as students, supported the research in every stages.
Then, let's get to introduction. The digital transformation of healthcare has profoundly impacted clinical practice, with electronic medical records now central to patient data management. EMRs serve as digital repositories, providing continuous, structured, and real-time access to vital patient information throughout their care journey. Regulatory oversight, notably Ministry of Health Decree number HK 02-2023-31788, has reinforced the need for robust risk management in healthcare. Despite extensive research on EMR and hospital risk management, a comprehensive analysis of their integration within Indonesian hospitals has been lacking, creating a critical research gap. This study aims to bridge this gap by investigating risk management practices within EMR implementation, covering technical, operational, and regulatory aspects. By incorporating perspectives from clinical staff, IT personnel, and hospital leadership, we seek to provide actionable recommendations for enhancing EMR governance, data protection, and service quality.
For the method, this research was conducted in 2 hospitals, DK Hospital and AK Hospital, located in Kudus, Central Java, Indonesia. A comparative qualitative research design was employed to explore and evaluate risk management practices associated with the implementation and utilization of electronic medical records, EMR, in the 2 hospitals. This design was considered appropriate because EMR risk management involves complex socio-technical interactions requiring interpretive understanding of behaviors, protocols, decision-making patterns, and organizational culture. The focus of analysis centered on 5 principal domains of EMR-related risk, as you can see here. These categories formed a structured analytical lens, enabling systematic cross-case comparison and mapping of vulnerability patterns across both institutions.
Our research strictly adhered to the highest ethical standards, ensuring participant protection and data integrity. We received ethical approval from the Institutional Review Board, IRB, of DK Hospital, approval numbers 67/KEPK/RSLH/VI/2025, issued 16 August 2025, for both participating hospitals. All participants provided written, informed consent after clear disclosure of research objectives, ensuring voluntary participation and the right to withdraw without consequence. No personal identifying information was retained. Raw data and recordings are securely stored for 5 years post-publication, then destroyed per data protection regulations. The study was conducted in strict adherence to Indonesian research ethics guidelines and the principles outlined in the Declaration of Helsinki.
The comparative analysis of EMR maturity using HIMSS MRAM indicators revealed a striking divergence in digital transformation trajectories between the 2 hospitals. As a district public hospital, DK Hospital demonstrated EMR maturity between Stage 2 and early Stage 3 of the HIMSS MRAM scale. This was marked by the integration of laboratory, radiology, and pharmacy services alongside functional digital documentation in emergency and ambulatory settings. Conversely, AK Hospital operates within stages 1 to 3 of the MRAM scale. Its EMR landscape is characterized by a modular, multi-vendor architecture, with system interoperability still under consolidation. This divergence reflects differences in strategic planning, budget priorities, and digital leadership, with DK Hospital benefiting from structured governance and continuous training despite financial constraints.
SWOT analysis revealed shared recognition of EMR development urgency, but stark differences in institutional capacity to capitalize on opportunities. Both hospitals recognized the urgency of EMR development amid national digitalization momentum, and both identified decision support potential as a transformative catalyst for service quality. However, internal capability differed sharply. DK Hospital demonstrated strengths in 3 major areas: integrated data repositories supporting clinical decision support, established risk identification frameworks with over 400 recorded risks annually, and continuous human capital upskilling and frontline retraining. However, structural constraints include only 7 IT personnel supporting hospital-wide infrastructure, 46% adequacy, leading to potential vulnerabilities in development velocity and emergency handling. Dependency on spreadsheet-based risk documentation limits analytical automation. AK Hospital presented a contrasting posture: strong cross-department collaboration and development autonomy. Limitations include a fragmented database architecture, slower adaptation by senior clinical staff, and emerging risk documentation practices still in early formation. The reliance on internal development, while reducing licensing costs, creates critical dependency on limited IT personnel, with high risks associated with staff turnover.
Evaluation using the PDCA cycle revealed both convergence and divergence in risk governance maturity between the hospitals. Both hospitals demonstrated robust hazard mapping for downtime, breach probability, and data entry errors, engaging risk management teams and end users. DK Hospital operationalized mitigation through dual-server backups, daily redundancy, and network failover, while AK Hospital built resilience via fiber optic backbone and multi-layer access control. DK Hospital implemented periodic reporting aligning with structured governance. In contrast, AK Hospital lacked a unified monitoring dashboard, creating compliance vulnerabilities. DK Hospital translated evaluation into iterative improvements and staff retraining, but AK Hospital initiated improvements, though institutional learning was slower. These differences highlight that transformative progress is influenced less by technological acquisition and more by the maturity of feedback loops and continuous improvement processes.
6 key risk categories were identified, each presenting varying vulnerabilities across the 2 hospitals. First, technical system risks. In DK Hospital, downtime reduced to 15 to 20 minutes, but billing system separation persisted, while AK Hospital fragmented databases and migration delays. Second, security privacy risk. Both offline secured architecture, DK Hospital, ad hoc documentation, AK Hospital lacked updated risk reassessment post-accreditation. Human error risk. DK Hospital mitigated via mandatory fields and onboarding. AK Hospital duplication errors and senior staff digital resistance. Fourth, regulatory compliance risk. Both hospitals shared the same risk: health insurance dependency, e-signature ambiguity, and pharmacy integration demands. Fifth, operational continuity. DK Hospital greater resilience but backup interval risks. AK Hospital paper fallback in emergency units. And finally, human resource concentration risk, where both hospitals are in the same situation in IT understaffing. DK Hospital, 46% workforce adequacy. AK Hospital, single developer dependency, risking total operational stall.
In conclusion, the empirical results of this comparative research reaffirm that electronic medical record EMR implementation is neither a purely technical endeavor nor an isolated managerial reform. Instead, it represents a cumulative organizational transformation reflecting the interplay of governance, digital literacy, system integration, and commitment to safety. Institution-wide reforms applicable to both hospitals include adoption of unified EMR risk management frameworks integrating MRAM, ISO 31000, and COBIT 5. Continuous monitoring with predictive incident detection and red flag early warning layers. Development of 24/7 rapid response teams for cyber and operational incident containment. Cybersecurity education for all employees to reinforce human firewall awareness. Research partnership development to sustain innovation in Indonesian digital health governance. This research underscores that effective EMR risk governance requires a paradigm shift from episodic incident response to proactive system stewardship, essential for safer, more efficient, and patient-centered healthcare.
Acknowledgement is extended to the 18 study participants, including hospital administrators, clinical departments, information technology units, and quality management teams, whose facilitation of access and provision of detailed contextual information enabled the execution of this comparative study. Their diverse perspectives were essential for understanding the complex and multidimensional challenges associated with EMR risk management in developing healthcare environments. Special thanks is also given to BIMA, Basis Informasi Penelitian dan Pengabdian kepada Masyarakat, and Ministry of Education, Culture, Research and Technology of Indonesia, Kemendikbudristek, for supplying research facilities, administrative assistance, and technical resources that significantly supported the study's implementation. And finally, to both hospitals for their generous support, access, and commitment to advancing safer and more effective EMR implementation through this research.